Thanks for staying around. I really appreciate it, and hopefully we're going to have an exciting panel. We're going to kind of go out in the audience and have you participate and ask questions in a little bit, and if you don't want to participate, we won't force you. But I do want to introduce our panel. First of all, from Vimty, the Chief Hopeful Idealist, Blaine Warkentine. Blaine, he'll be out in a second. Randy Eager, he's an Industry Liaison Officer at Carnegie Mellon. Lucas Merrow, he's the founder and CTO of Eliza. And Jeff Makowka, Senior Strategic Advisor, Thought Leadership of the AARP. My philosophy with panels is there's nothing that's written ahead of time. We're going to really just have a great conversation and talk about the issues and the concerns that are most important to them and also to you, so that we'll have a great experience. So I guess I could start maybe when I was backstage, I was talking to Lucas, and I said, tell me a little bit about Eliza, what you do and what's exciting about your company and why you're here today.
Sure. So Eliza is a leader in the field of health engagement management. And what that means is we get information from health plans, health providers, and third-party sources. And we get a tremendous amount of information from actual healthcare consumers. And we use that data to conduct digital interactions with folks about their healthcare and their health. And our mission is to basically help individual healthcare consumers be more engaged and activated in their health so they can be healthier every day. Last year, I started the company with two co-founders a little over 10 years ago. And last year, we interacted with just north of 52 million individual American healthcare consumers for about 120 leading health plans, providers, and retail pharmacies across the country. So the whole key and sort of reason for being for Eliza is basically getting the individual consumer activated into their own healthcare and using data and using their own information to sort of reach them by the channel at the time with the content that they feel is most effective and authentic for them.
And by the way, you obviously have access. You have everybody's Twitter accounts, and you can write us. You have questions later on. We're all open to that or want to continue the discussion in any way. Randy, you're an Industry Liaison Officer at Carnegie Mellon. You mentioned you're really at Carnegie Mellon, the University of Pittsburgh, and I mentioned my son's a freshman at the University of Pittsburgh, and you talk about quality of life. I wish I had his quality of life as a freshman in college. Tell me a little about what you do in the college environment and how you're taking this, obviously, and impacting more people.
No, I'm not helping him with drinking games. I'm not, I promise.
That's good to know.
So the title is a little odd, but I'm part of the Quality of Life Technology Center, which is a National Science Foundation engineering research center. This is a $40 million grant over 10 years, and it is a joint center between University of Pittsburgh and Carnegie Mellon. We're actually within the Robotics Institute at Carnegie Mellon, and what Pitt brings, there's a medical school and related areas of focus. So they bring the clinician side to the center.
Okay, and we're going to obviously talk a little more as we go on about that, but I want to move on now to Blaine, and you are a Chief Hopeful Idealist. That is a great title, probably the best title on the panel. Tell me about a Chief Hopeful Idealist.
Mine's pretty good too.
I'll get to yours.
All right. I'm a medical doctor, an orthopedic surgeon, but I ultimately saw that there was a real big disparity between how we were choosing to live our end of life and what we were able to deliver as a healthcare industry relative to that issue. And so I hold out hope for that alternative where people actually make their own decisions and we are able to execute in that way. So it's a weird title, I know, but I'd hate to call myself a CEO because we're a startup.
No, and I like that. I like that title. And Jeff, we'll get to your title. You are a Senior Strategic Advisor. That's kind of boring. But Thought Leadership at AARP. That's pretty impressive. So tell me about that.
Yeah, it's funny. My boss, Jody Holtzman, often says when he's on stage, if anyone can come up with a more ostentatious title for a group, please let him know, because he's Senior Vice President of Thought Leadership. But our role within AARP is to try to stimulate innovation and technologies that help benefit people over 50, which is our main core demographic that we represent. So we're trying to do that by stimulating innovation, by creating pathways where our members, and some of which are here in the audience, and some have been circulating around the hallways, and I'm excited to hear their feedback, how we can introduce them to innovators and technologists as they're beginning to develop their products, so that there can be direct influence for things to make the products more relevant and help people live better lives. Okay.
One of the things I've learned from doing radio and TV over the years is you just kind of ask for what you need when you need it. And is there a portable mic I could get? Because I'd like to go around the audience, and I'll figure out how I get down. That'll be my next thing to do. And then we'll try to ask questions from the floor and see if we can get a discussion going and continue with your input. But let me ask the panel, maybe we'll just start with the whole idea of thought leadership, AARP. You know, the image has always been AARP. Why would they be interested in innovation? Why would they be? And I think the real reality is, no, if you're 50 or over, there's a lot of great ideas coming from this group, and there's a lot to do. So tell me a little bit about that.
Yeah, there really are two sides of it. So the mission of our specific group is to encourage this innovation, either by people over 50, so helping people who might want to be later life innovators and entrepreneurs, giving them the tools and the resources to do so, or people of any age that are focused on the 50 plus. And so in different ways, through whether it's industry outreach, providing research and insights, or demonstrating the real needs and wants of people over 50, we're hoping to draw attention and increase and stimulate activity, and then ideally getting smaller companies that are focusing on this and really improving the quality of life for folks, get them funding, get them to market faster with better products and services. Where'd you go? There you go.
I'm now on radio. I've moved out here. It's great to be off camera and less pressure, but let me ask if there's anybody here who would have a question for our panel just right off the start, knowing what they're talking about. Anybody have a question yet? If not, that's okay, but anybody? No? Okay, let me continue then. I want to talk a little bit about when you talk about your company, Vimty, and we saw a little bit about some of the little bit about what you do for that 1 minute bridge there. Tell me a little bit about end-of-life concerns and those things, because clearly, you know, orthopedics isn't the first place I would look at. Not to say I'm prejudiced as a family doctor, but being the sensitive, caring human being who would get into this, I just would think you'd just be in the operating room, breaking bones and moving on. But how'd you get involved?
Yeah, I think, so I actually worked with David Nash, who spoke earlier in population health, and I discovered that it's, you know, roughly 50% of healthcare costs. So under that umbrella, we have to really inspect what we're doing with these resources. And I think the most obvious one is that if you don't make the decision for yourself, someone else will. And leaving that window open for others to make the decision allows for your wishes basically to be unmet. And the way they're unmet is actually really disparaging. About 80% of us would prefer to be at home in our last days, and yet 80% of us are in the hospital instead. 30% of us are having surgery in our last month of life. 50% of cancer patients are still in chemotherapy within 2 weeks of their death. We're just making a lot of choices around resources and how we expend them in these last and final days that don't provide, in real terms, they don't provide any quality of life. There's been new evidence from New England Journal of Medicine just 2 months back that actually shows the longevity to be shortened as well with the great aggressive treatment. So looking at the whole picture around what it means to go from volume, which is face-to-face visits with physicians, fee-for-service, those kinds of conditions, to this new model, which is really a part of Obamacare's future, and really I think, you know, America's future, where we look at value, the value of these services, because it's all of our money that we're spending in this direction, and it's all of our quality of life that we need to be looking for. So looking in this new world value, it's really not a lot different than shopping at Walmart. It's really outcomes or a value is outcomes over cost. And I think the numerator is a really important figure. If you had to ask people what is an outcome in healthcare, I think you get a lot of question marks. But clearly, in this particular instance around end of life, it's likely to be zero, if not negative. So that was the focus.
Lucas, I was going to ask you then, you know, you look at a lot of data and you see, is that a concern? Do you get reflections on people, what they're talking about, end-of-life treatment or family members, those kind of things, and what's your take on it?
Yeah, so not, the majority of Eliza's work is around helping folks manage chronic conditions, not to the end-of-life full cycle, but from diagnosis through management of a chronic condition, and also helping people manage day-to-day wellness, to staying healthy, getting preventative screenings, everything from cancer screenings to diabetic screenings to well baby visits and things of that nature. But the sort of stuff that Vimty is doing it's really the same theme, which is how do you get the consumer more involved in making important resource decisions. In our case, it's how do we understand the motivations to taking better care of yourself so you can have the best quality of life up until your end of days, and understanding what barriers there might be for you in doing that. And the interesting thing, from our standpoint, Eliza is actually my third startup in healthcare. And the motivations that individuals have to taking better care of themselves, and the barriers that they see in doing so, and the barriers that they encounter in terms of the really big decisions like Vimty is trying to manage, haven't changed all that much. I think we've made some improvement over time, but they really haven't changed. I think the really interesting thing is we're finally at a point where there's a confluence of forcing functions. Certainly healthcare reform, certainly just the burden, of cost on the government, on employers, and on individuals has given, I think, finally a lot of real momentum that we see in our customer base. And I think the other forcing function is technology. There's finally technology which is very available, very scalable, extremely affordable, where you can reach folks and you can understand at really a very, very granular level and serve up information to them in a manner that they're going to respond to and measure how they respond. And that really is new. And I think one of the things we've seen in literally the last 2 to 3 years, I think healthcare organizations, understandably so, and I think rightfully so in the past, have been fairly conservative about trying new things and innovating and taking risk. And we've seen, really across the board, our customers, both internally trying new things, and as the prior panel mentioned, being willing. Part of innovation is being willing to fail, and being very open about, look, we're going to fail, we're going to trip, and we want to be public and acknowledge that and have that be part of our culture. And then in working with companies like Eliza and saying, okay, where in the past what you were talking about might have been what we would consider more bleeding edge or sort of out of our comfort zone, now we want to sit down and get very serious about it.
Both of you bring up points I think are really interesting, because I work in family medicine when I'm not doing broadcasting. And as a family doc, my goal for 30 years has been keep people out of the hospital, do whatever you can. And working as a faculty member in a residency program in a hospital, I've been always in a world where the whole goal was to bring people into the hospital, get them in, take care of them, you can bill them when they're in there, order tests, do all those things. Finally, I'm starting to see, and what you're both talking about, finally there is an alignment. Insurance companies are saying, wait a minute, if we make people healthier over a long period of time, that's to our advantage. If we keep them out of the hospital, that's to our advantage. Hospitals are now saying, wait a minute, we got to get people out as quick as we can in a healthy way. How do we do it? And finally, like in my role, I'm now able to really be rewarded for trying to keep people out of the hospital. There's always this opposition. And if I have any hope for healthcare in the next 10 years, it's that it seems like finally everybody's starting to get on the same page. You talk about what you're doing is you're talking about quality of life. In other words, when you're young, when you're 40, when you're 80, whatever it is, you have that opportunity to be watched in your own home, do things that make you healthier, and those steps. So I think there's some optimism here. I do want to hear from people. Anybody hate the healthcare system, hate what's being done, and want to talk about it, or have views? Have you found your experiences any different? I'll start picking people out if nobody volunteers soon. Yes?
Actually, I have a question. The question I have is Medicare and Medicaid. On the lowest end of Medicare, you don't have silver sneakers for seniors. Medicaid, I assume, has nothing either. Both of those are strong expenses, shall we say. Why don't they have silver sneakers programs to help those people? Why don't they have nutrition to help those people? Because that's the burden. I don't think anyone's addressed that. Does anyone have an answer for me?
Sure.
Yeah.
Go ahead.
I mean, I think
You're a thought leader.
No, I think you're pointing on something. We do live in something of a healthcare, or more a sickness care paradigm than we do a health and wellness paradigm. So I think the emphasis has always been in the past. What's the problem? What do we leverage to fix it? And then how do we get the person out the door? And instead, and to Brian's point, I think what needs to change is what are we doing now in small steps? What are things, whether it's technologies or just lifestyle changes or just philosophical changes? What do we do now in small steps to keep people out of that system, keep people out of the office, and more healthy and well? Sounds like a quality of life thing.
It can be. The Quality of Life Technology Center, again, is focused on improving the quality of life for everyone, but really focused on the elderly and persons with disability. And if I could boil it down even more, it's about keeping people independent longer. So allowing you to stay at home longer, and it's 30 or 40 projects a year over 10 years is the initial funding, and it ranges anywhere from safe driving, which is we have technologies that allow you to technologies that park your car for you, automated driving. But I think what will really help is as we age and our cognitive ability declines, the safe driving, just one example, safe driving, there's some technology that allows you to, that aids you in driving, alerts you of lane changing issues, of many issues related to cognitive decline. So this is just one example.
Other questions from the audience? Yes, I'm coming down, that's good. Because I think there's so many issues we can go to with this and with this panel, but hi.
I'd like to ask Lucas about the issue that you raised about communicating with people about their diseases and using their information. And let's just take diabetes for a moment and focus on that and ask you, how is what you do different than what happens in a physician's office? And how is what you do different than what happens through United Healthcare, through AARP, in advising people about their diabetes? And how does that relate to what we were just talking about in terms of quality of life issues that come up in all environments that relate to healthcare?
Great question. United's actually a customer, I'm happy to say. And I think it's not so much that it's a difference as Eliza represents an analytic and a scalable outreach support tool. And so when we work with our customers who are primarily large health plans, large delivery systems, large pharmacy benefit management firms, we basically have a platform where we can go to them and let them configure content that is supportive of what might be going on their platforms or in their physician offices, and trigger the outreaches on a schedule and across channels that are commensurate with what might be going on in the patient's treatment plan. And so in general, what we're trying to do is just extend the reach to folks, for the whatever number of days it is that they're not in their doc's office or they're not talking to the disease management nurse.
Just extend my question then. In looking at the issue of diabetes, the New England Journal of Medicine recently reported that over the last decade, the outcomes with regard to diabetes really have not improved dramatically. There's been some improvement, yes, but not dramatic improvement. Looking forward, how do you see your interface with people with diabetes improving those kinds of outcomes?
Yep. That's a good question. I will say that in Eliza's case, given our sort of scale in delivering population management, very cost effectively, we actually have had some good outcomes in the diabetes space. But when we've had them, it's not as if we did that alone. Where we see the best outcomes is when our technology is used as an integrated part of an overall strategy and communication plan with the customer. It's not nearly as simple. Obviously, I think everyone in this room knows, how difficult it is to move the needle on some of these conditions and how difficult it is to sustain real behavior change. And the key, we haven't found a magic bullet, and I'm certainly not saying that Eliza is a magic bullet, but when we work closely in concert with our customers in terms of the content that they've seen be most effective, the power that our platform brings is we can deliver that the same way every single time, and then watch, essentially on internet time, in a very data-driven way, what's working or not. So we can actually tell you when you use this channel versus that channel, when you use this content approach, you're a gentle coach versus you're a drill sergeant, for example. You move the needle for these types of people, and you don't move the needle for these types of people. And sometimes that's great news and confirms what folks are thinking. Sometimes it can be a bit unsettling, for our customers and for us. The interesting thing about not just Eliza, but a lot of the technologies that are out there, and in talking to a lot of the entrepreneurs in the showcase, is you can't hide from the data anymore. And it actually sort of gets back to your question, which is one of the reasons that programs like Silver Sneakers have been adopted in some places and not others, is healthcare hasn't done such a great job in the past at tying those programs to actual outcomes. And that's changing, and it's actually changing, it's accelerating the rate at which it's changing. And I think that's good news. The potentially bad news is hopefully, if you're a fan of the Silver Sneakers program, you're going to find that actually helps people, be healthier, live longer, avoid hospitalizations, and that'll get adopted more broadly. There are going to be cases where the outcomes are going to be shown not to prove out. And maybe not Silver Sneakers, but other programs, other devices, other products may not pass that grade. But, we just made the point that finally, I don't think all the different constituents in healthcare are fully aligned, but they're largely aligned. And I think health insurers are sometimes painted with a brush as being sort of the evil, you can't have it, we won't refund it. But if you think about it, in the world going forward, they actually want the same thing you want. They want you to have a long, healthy life, stay healthy, and I joke with my wife, and someday just sort of explode. Like, don't get sick, don't get hospitalized, just boom. You had a great life, and you didn't see it coming, they didn't see it coming, and you were a great customer, you didn't incur a lot of expenses, you didn't want to be in the hospital anyway, and everybody wins. Now, the real world is much more complicated than that, but I think healthcare is finally catching up to say, well, how do we actually measure those things, and how do we engage the consumers? Because the individuals in this room, the individual patients, and all of us as individual consumers, we're the ones who drive, between us and our physicians, we drive those decisions, to the vast, vast degree, and that's really where we're all headed.
It's interesting. One of the fun things I get to do is host a talk show or interview different physicians, and there was a gentleman, Dr. Lou, and Dr. Lou became my guest because he was named one of the top 100 doctors of the century in Canada. And I just wanted to know how you get to be one of the top 100 doctors of the century. I mean, you work hard, and how do you get that, and who puts the list together? And I asked him that. He said, it was just some organization. So I was kind of disappointed. But what I wasn't disappointed was when he started speaking. And what he said is, we call it a healthcare system. But really, who in a healthcare system wants to be in a hospital? Who says, today I'm going to the emergency room. This is going to be great. You don't think about that. You want to stay out. So if we can provide things to allow people in a healthy way to stay out, everything's aligned. And I know in my career, the last 10 years, two of the biggest things I've seen is the focus on evidence-based decision-making and the alignment with quality. And now that we're getting the technology there to measure it, like you say, you can't run and hide, you can start saying, is this evidence-based? Does this lead to quality outcomes? And now things can be measured, and if you align the payments with that, people are going to do a lot better. You wanted to make a point?
I think it's really exciting. I think this conference is going to be a lot different next year. I think, when we look at the insurance and how it's going to be restructured around people having choice and going to healthcare.gov and making decisions in a unique way and actually discovering and thinking about it slightly differently, perhaps, potentially much deeper about their choices, I think it's going to naturally gravitate towards more consumer engagement. They're going to have the tools and the skill level probably to make deeper and more profound, interesting types of decisions. And I think that's really the scalability that could enter into the conversation around healthcare. you know, for eons, or at least, you know, 100 years, we've been really faced with, you know, a pipeline that involves a face-to-face visit. Well, that's not very scalable. You can only do so many of those in a day, and they're fairly expensive. And I think Eliza and many of the technologies that we're bringing to the table today are trying to scale the business of what it means to understand your own health. That's really an interesting opportunity when consumers are then also enabled to choose their insurance plan. And so I think it'll be interesting to see how people adapt and companies adapt to that new world.
Okay, you got a question?
Yeah. My question deals with end of life. If and when one does decide to write a living will and choose how you want to die, is there any way of ensuring that that will definitely happen as you wish? Can your children overturn that? Can your spouse overturn that?
Yes, so advanced directives in general, living wills, these are not legal binding contracts. They're actually just medical directives. You can put as much horsepower between them and the system as you want, but inevitably there's always the chance when you're not able to, for your actual health advocate or your healthcare proxy or your power of attorney for health, which are all bad terms, by the way, they're all legalese, to actually override your decision at that piece of paper. That's why one of the pieces that we've put together for Vimty is not just what we call it's an e-notary process, so that you can do it all and remain digital throughout the process, but we also ask 15 questions, and we secure a video of your actual decisions in an open-ended question format, which really gets to the heart of the issue, which is, I want to see your face describe to me what you would like. And when I see your face describing that on a video, I think it's a lot different than looking at a piece of paper with some check marks on it. So I think when we look to the future, what is an advanced directive? I think we ought to be looking at how do we use what's currently available and utilized rather readily and easily, i.e. this webcam type of format, to actually expose your true ideas and wishes from your own mouth and face and that kind of thing. And I think at that point it'll be much harder to ignore. And I imagine you agree with me on that issue.
And I will tell you that one of the things that I've noticed is, well, two things I've noticed is in my year's practice is, one is it's frustrating when you don't have that piece of paper and you have somebody on event or whatever because you didn't know. The other thing is having that document, that video, whatever. The nicest way to put it is a lot of people, when a loved one is dying, feel guilty. And many times, especially kids who feel guilty, want to do everything. And in their minds, they think, I didn't do enough while they were alive. I didn't do enough. I'm doing it now. And sometimes that can be the worst thing, but you're trying to guide people through this. And if the decision wasn't made, all it takes is one. And that one person says, do it all. We're bound, essentially, to do it all. And you start seeing the blood tests and the labs and the CAT scans and the procedures and all those things. So it's really important that you kind of tie it up and you decide what it is you want. And that's what you have to figure out. And the other thing, I guess the last point is, you want to make sure that that doesn't mean no care either. Because you said, I'm not going to want this at this point, all the other steps need to be taken and you need to be treated with respect and dignity and all those things. I think you had a question.
By the way, thank you. That's actually where the rubber meets the road, and thank you for that question.
And this is a question, I'd love the feedback for the AARP members who are here who had a chance to look through the Startup Showcase, but I think this goes for anybody who was here and looked into the Startup Showcase. I'm interested in which startup everybody liked the best. And I guess if liked has to be quantified, which company was most likely to make you better? And I'm not going to tell you my favorite because I guess I'm not supposed to pick one. But Buzzy, the little device that deadened your needle sticks. Now, it's not very high tech. In fact, it was made by another massaging device that people put together. But it seemed to tackle one of the things very simply. People stop going to the doctor or stop taking their medications because they have to get injections all the time and they hate injections. And if you suddenly take a pain away, that has a positive effect. That was my idea, and I'd be interested to hear what other people thought. There were other more sophisticated. Vimty is a beautiful and elegant example of an end-of-life decision. There was another around being able to see newborn children from far away, and I'd welcome anybody else who saw one of the products that was in the Startup Showcase that they thought was pretty amazing that they were going to see again and again.
here, good.
So one way is they do the blood, and they don't prick your finger. They use their put it in your mouth. I like that.
And again, you're not having the pain of pricking the finger. Other things, anybody else? Okay, here I come.
Excuse me. I like the one about dealt with hospice care, where instead of the person, once they reach the end of their life and they were dying, instead of staying in the hospital, have a chance to go home and still get the same care with the nurse, the aides, and whomever they need at home. Even if they was at the hospital, they could still get it at home. I like that part, even though I enjoyed all of them, but that one stood out more to me.
Anyone else have any over here? I'm being pointed over here, but let me see where. I'm missing you. Right here? Where am I? I don't know. I thought there was someone.
Because the air care, I think, was similar. It was personalized. When you get discharged, you felt a comfort in knowing that you can get personalized care when you got home to monitor you. I thought that air care was good.
You know, what I see, just the people in this room right now, is what we're looking at as the greatest technology are things that make you live a more normal life and not experience pain. I mean, it sounds like, you know, you want to be home with your loved ones. You know, nobody wants to be in the hospital, maybe for a day, but then they want to go home. And when people want to stay in the hospital, I wonder, like, why do you still want to be here? Like, what is it? Like, then I start to wonder, what's wrong at home? And why are you here? And you start to ask those questions, and sometimes that's a very real question with a challenged population. But let me ask our other two panelists. You've been quiet, probably as a thought leader. You've been thinking. But tell me a little bit about, what do you see? What haven't we covered that you think is important that you'd like to talk about?
Well, I'd like to, if there are any of the innovators or the folks that were in the showcase, the actual entrepreneurs, if they gained any interesting feedback from interacting with our members. Because sort of what our group is trying to do, and when Chris and I cooked up this concept for this interaction within the conference, was try to get this to a, you know, what otherwise would have been a pharma-focused, payer provider focused conference, try to bring some consumers in, and I won't say do a breath of fresh air because I go to enough of these conferences, but get that interaction again at an early stage in a company's life cycle to see if anybody learned anything, they might do anything differently with their product. I don't. You mentioned that you were surprised.
Yeah, I spoke with a good majority of the AARP members, and you know, I asked a few questions. Did they know what an advance directive was? Number one, and you know, I think this is probably standard. Only about half did know what an advance directive was. The other question I asked is, do you have an email? And again, that was maybe 60 or 70% had an email. So we still have a lot of, you know, work to do, as you can imagine, regarding you know, these two topics, at least for me. But I'm sure, you know, there was other issues that have been brought up.
Anybody else have a question or thought? Okay, I'm coming.
I would actually like to ask some of the AARP folks. We have been talking a lot yesterday and today about doing more remote monitoring, remote talking to your doctor, emailing, that sort of thing, as opposed to always going to the doctor appointment face-to-face. So I would really look to you guys for your feedback on what you would think of that. If you were to be able to see your doctor, you know, over the computer, or email him, or another way, as opposed to having to actually drive there. Let's say if it was not for every instance, but let's say you had a rash and you're allergic to poison ivy or whatnot, you could take a picture and send it to your doctor, and they'd be able to get back to you, as opposed to actually driving in. And I'm seeing a shaking head, and I'm playing Oprah right now.
I do not have a computer.
Okay. So that's interesting, because we're all trying to solve problems with creating different services and products. So anybody with additional feedback on remote?
Oh, here we go. Yes.
Okay. I think it's an excellent idea. It seems like recently a doctor's visit is not like it used to be. Doctors are in a hurry. they have an assistant inputting information as you give it, and they just don't seem to have the time. So if there were a remote idea that we could use in order to communicate with your doctor, a lot of things. A lot of seniors today are home by themselves. So it would be also beneficial to be able to communicate with a doctor on a basis for a lot of things that we may think are not important, but when you call a doctor and he says, yes, come in right away.
Mm-hmm. And you made a point, I'll address that.
No, I don't have a problem with that. I don't have a problem with my doctor, getting to see my doctor. And maybe if I did, I would want a computer, but right now I don't see a need for a computer.
Well, it sounds to me like there's room for both. To your point, I will tell you there's a constant pressure being a family doctor. I'm in an educational setting, so I get a little more time than most, but even then, there's a pressure. I think it's 6 minutes and 20 seconds is the number that you're supposed to spend with a patient to make it work if you want to just break even. And you look at that and you go, what can you get done in 6 minutes and 20 seconds? I mean, I can't even, make a bank account withdrawal in 6 minutes and 20 seconds. This is going to be the doctor's visit. So, a lot of questions. Eric Topol, I don't know how many of you heard of him, but Dr. Eric Topol is the doctor who's a thought leader as well, and he's a big proponent of that. Having some remote visits split in with the others, and I think the technology is there. I'm constantly getting people's iPhone pictures, and you're just being a family doctor, what do you think this is? And I go, look, you should see your doctor, but looks to me like a spider bite, and then you're like, what am I doing? But the point is, people can reach out to you and you can help. And then I ask for their insurance card. No. Go ahead.
Yeah, kind of a variation on the telemedicine that might be more acceptable to people than not being able to see their doctor face to face. And we're very lucky, we're living here in the Philadelphia area where there's tremendous academic medical centers. We have tremendous resources. But if you're in a more rural area, or if you need to see a specialist that is, in New York, and there isn't anybody in Philly that, that's that kind of a specialist, to have your doctor be able to consult, bring you in his office, it's his computer, you don't have to have a computer, consult with this specialist, rather than send you to, to New York or to Cleveland or wherever to see the specialist. Doesn't that make sense?
No, and it's happening. I'm going to come over here. It's happening. I know that I was out to dinner last night with a couple of people. There's a school in Nigeria called the Babcock University, and they want us to lecture to their students. And we're going to do it remotely through a smartboard and talk to medical students in Nigeria as part of their school and education. And we're going to be talking, showing x-rays and things. So you could address patients at that level, too. Who hasn't asked a question? I think, let me get you and you. Go ahead.
I just have a comment to make. The technology idea is wonderful, and I think it's probably the way for the future, but CMS currently is not on your side. Yeah. And you might want to really think about talking with those people because, for example, if you need a piece of medical equipment that requires a script, they're about to mandate that every patient go to see a physician and have a face-to-face, quote-unquote, visit within a certain time frame if you want to get that piece of equipment. Now, they've already done it with oxygen. They've been doing that for years. But this is clearly not going to save money. It's going to create more complexity, I think, in a system that already is broken. Clearly, they really are in desperate need of financing. But I think people like you, it would really behoove you to talk with the government because you're not on the same page.
Okay. I will have my one negative government comment through this whole thing is I think what we need to do, what we're looking at meaningful use and all these steps that things hospitals and doctors are going through. Right now, they're not focusing on what's important, which is care. They're focusing on data collection. And I long for the day when they're going to be rewarding people for using their iPhones to look at rhythm strips, and they're doing these things. Right now, it's all about demographics and data, and we got to get to a better point. But I'm giving everybody a free pass because I'm figuring it's new, and they're just getting people on board. But we do have to make that transition into what will be real care, patient portals, education, those things. Go ahead.
I actually run a patient advocacy and health and wellness firm. We're all registered nurses, and so we've been doing this for quite a few years. And so what I would like to say is what we've heard consistently from all of our clients, so we're at the really grassroots, is I don't feel like I'm connected. I don't feel like people communicate with me, and I feel like I'm in a cattle chute and people are just herding me through and no one is listening. The other thing we've learned, even though we take care of everyone from children to the elderly, most of our clients are adult children of older parents. And what we have found is it goes back to the old adage, know your audience, know your clients. The older generation is really not into all that technology. We're in and out of almost all the assisted living facilities in this whole Tri-County area. Most of them look forward to their doctor visit. They look forward to getting out. They get dressed up. It's their social time. It's their time to get out and interact with society and get out of the assisted living facility, to get out of that arena. You'll be surprised how for that elderly person, that's a huge psychological boost. So there's a place for technology, but there's place for the one-on-one touch, and we can't forget the one-on-one touch.
No, you're exactly right, and it's got to be more than 6 minutes and 20 seconds, so we have to find a way to allow them to have that time. Yes?
Well, there's been a recent analysis on the time it takes for a patient to actually go visit the doctor and get back to their to this issue, and I think on the average, in aggregate, it's around 2.5 hours. So if you add a caregiver in that mix, you're now twice as much. So the 6 minutes that you're exposed to the physician is swapping it for a 2.5 hour kind of experience. I mean, I can see the value in that, absolutely, but for an incision check, there might be an easier avenue for getting that done.
I wanted to scare these guys and get behind them. We have about 5 minutes. Maybe if each person could make, a summative point that you feel is important. We'll start down here with Carnegie Mellon, Pittsburgh. Go from here, then we'll head the thought leader.
I think the one thing that we do that's relevant to this last comment was that we have a consortium of companies that support the center and have access to the intellectual property that comes out of it. But our core members are continuing care retirement communities, ranging from home health all the way to critical nursing. And this is really our core membership, and we're charged with our center is a little different than normal, typical university research, where we're charged with taking ideas in the early days of the center and transitioning them from creating knowledge to really creating innovation and then testing in, let's call them beta sites. And our core members, I see this all the time of how excited they are, and our members are allowed to use our technologies in tests in their facility. And all of the residents are so excited to be testing new things and to be trying out new technologies. And we gain from it, they gain from it. The organization that's sponsoring it, that's our members, gain from it by looking as though they're, actually they are, and the forefront of caring for seniors. So it's a great blend, and I really appreciate the support of the organizations and, of course, their residents.
With the AARP, I got to ask this question to you. It's that what we're hearing is we're in a really weird stage, not only in healthcare where there's transitions, but also in the patient populations we're serving. That, some want that visit to the doctor and the time. Some want the technology. And I think, I got to tell you, at least my experience is, I can't actually pick out which of my patients like the technology and which don't. I get surprised. I have some older patients who are really savvy and are asking me questions about why my EMR doesn't do something. I'm like, are you kidding me? And then I have younger people who have no interest. So I don't even know if it's an age divide. I'm sure there's some of it, and you probably have the stats. But tell me, from an AARP standpoint, as you're dealing with your membership, what is the acceptance and where are they as a group?
In terms of technology adoption, and so it's pretty interesting. I mean, some of it is what you would expect, sort of the the younger boomer cohort, let's say, from from about 50 to about 55 are a little bit more tech savvy. But again, it's not age related. So a story I use very often is, I hope all of you are familiar with Skype, or you've heard of Skype, right? So I live in Baltimore, Maryland. My parents live in southwestern Connecticut. So I don't call home enough. I'm a typical son. I don't talk home enough. They want to hear their grandkids. They want to talk to them. My kids don't want to talk on the phone for more than 2 seconds to Mimi and Papa up in Connecticut, because they just don't see any value in it, which is a shame. But so I said to my dad, why don't you go and get Skype? It's this free service, and then you can communicate with your grandkids. We'll bring the laptop out and do it. Now, my dad's by no means a technophobe, but he does get frustrated and annoyed, especially working with Windows, on installing a new device. But lo and behold, because he was excited and my mom was excited to have better access to my kids, their grandkids, they went out and bought a webcam, they installed it, they got the drivers down, they created a Skype account, and they got it done. And they were actually able to participate, and I don't want to gross anyone out, in the potty training of my 3-year-old, because we were able to bring our laptop in, set it on the side of the bathtub, and have them encourage my daughter to use the potty, right? So what an interesting sort of life moment that happened that was enabled by technology. It wasn't technology for technology's sake, but it was able to bring them in, and they went about and found out how to do it without any encouragement. I wasn't their remote IT support guy. They actually pulled it off. So my point would be is things can be made better, more ease of use and those sorts of things, but there has to be a reason and a value to someone's life to have them adopt them. And you'd be amazed what people will do when they see that value proposition.
You brought an image to me of, anybody watch The Big Bang Theory ever? It's on all the time, where the parents of one of the characters are always on Skype, and they have a running joke because all these bizarre things are happening while they're watching, and the parents are like, what's going on there? But it shows, again, how the technology has weaved its way into television. Okay, we've got 2 more, minute 40.
Sure.
What would you like to talk about?
Yeah, so that last comment I think was spot on. But it's not an either or. Really, what everybody's describing here is an industry that's becoming more customer focused and trying to figure out what is the method by which you want to interact with the healthcare system. And historically, there was much more physician to patient interaction, and I think the pendulum over the last 20 or 30 years swung back, where in many respects individual healthcare consumer was almost an afterthought, and it was much more of a business to business kind of process and concern. And the key going forward is, if someone wants that interaction with the physician, with their primary care physician, they should have that. That's a great way to avoid longer term complications. If someone doesn't have a computer, one of the channels that Eliza uses, it's actually our most effective, is a telephone. Everybody's got a telephone. If you happen to have a computer, then we can send you emails. If you have a mobile device, we can send you text messages and push messages to your application on your mobile device. So it's really what works best for you. Some of the interesting things we've seen is sometimes folks' stated preference is not always the preference that keeps them the healthiest. And so I also think that as individuals, all of us as consumers are also figuring out, hey, what actually is going to work best for me? It might be in some cases getting to the doctor's office with my younger daughter to get that social interaction. In other cases, I might need help now. I might need help off hours, and doing it over a computer might be more effective. So.
Okay.
I think
last comment.
I think there's technologies like iPads that are enabling people with macular degeneration to read books for the first time in 20 years. There's, they're fairly simply to use. They're, they have cameras built into them, and I would just encourage anybody that's thinking about the role that technology might play in their lives to, go out and try them, because they're not as difficult as you might have thought in the past. And so we're experiencing kind of an expansion of these tools. And they do offer a unique way at looking at how you solve problems in your lives with a lot less effort and a lot less, struggle, and probably in some sense give you the tools that you're going to need to adapt to the changing environment, in particular in healthcare, but perhaps giving you gifts outside of that as well.
I want to thank our panel. I want to thank all of you, because the last panel of the day, it gets late and I'm sure you're tired, and it was really energetic, and I think we had a great discussion. So thanks to all of you, and thanks to you, and thanks for being here.